Good morning and aloha. I'm James. Aloha. I'm James Chen from the class of 2015. It's an honor for me today to be introducing our excellent panel here. And this section, we're going to talk about the business case of investing in social determinant of health. And as I was talking to the class of 2015, my friends, and from my personal experience, I think if you talk about this 7 years ago, when as a CFO, when I was at the table negotiating contract with the health plan or system, I think I got a sense that the plans really were kicking and screaming to come to the table to talk about investing in services that are not really billable or by a code. And I feel that right now they're actively participating, at the table. And in my case, I think all 4 of the Medicaid managed care plans has committed to investing dollars, PMPMs, into care management supportive services that are really not remunerated in the premium. So they're doing that, and they're really, really going down this path with the providers. So as I was listening to David, it really echoed because, I really thought about the wisdom of the founder of my organization. We are a product of the Great Society of President Lyndon Johnson. The Health Center was founded in 1969, and if you look at how it was founded, it truly anchor mission and place-based. So I'm happy to talk a little bit about that, and I'm hoping that it's not going to take away too much time from our panel. So if you look at how we organize, it's truly community-owned and operated. We have 15 board members, 15-member boards, and if you look at it, 2/3 of them live and work in the community. 1/3 is brought on, for their expertise. But so the way I look at that is that, we proud ourselves to be the engine of the community, economic engine of the community. Just in pure number, we are pumping about $2 million payroll every 2 weeks into the community. And this is a community that is economically disadvantaged. And if you look at, all the social economic index, and it is a very, very depressed community. So as I listen to David, it really come back to me and feeling like very much so. I think the wisdom of our founder. And also as a CFO, a lot of time, we get asked for all these new initiatives. And I think over this last few years, we've really employed a more flexible capital model, I would say. Because a lot of the time we focus on return on investment, what is the cost of capital, do you meet that threshold, et cetera, et cetera. But, I think for the last 5 years, we've invested upwards of $5 million each year in community health services. Some of the example I can give you is like school-based clinic. We have 4 school-based clinics right now. We put an APRN and a psychologist in the clinic, in the schools. And we were able to return more than 90% of the students back to the classroom. And so that's a wonderful result. So as we look at return on investment, I think we're going to have to broaden that definition to include some form of a social return on investment. Anyway, without further ado, I'm going to introduce our panelist and our facilitator today. And let's see if I can find it here. And we have Dr. Robert Green. He's a national leader and a consultant in healthcare transformation. And he's going to help facilitate this panel. The first presentation is going to be by Christina Severin. She is the president CEO of Community Care Cooperatives, C3, a Massachusetts nonprofit company organized by federal health centers. It's an ACO. And that's Christina. And then to Christina's left, we have Sally Kraft. Sally is the VP of Population Health at Dartmouth Hitchcock. She leads a multidisciplinary team dedicated to improving the health of the population and the communities across the region. To her left, we have Nobodo Menendez. Nob is the CEO and one of the founders of Life Wallet, a company transforming the healthcare delivery models and by enabling consumers to own their health. Last but not least, we have Dr. Luther Brewster. Dr. Brewster is a faculty member of the College of Public Health and also a faculty member of the College of Medicine at Florida International University. So without further ado, I'm going to give the podium to Dr. Green.
Thanks, James, and thanks everybody for being here. I really appreciate the opportunity to help with this panel discussion. So we'll have a series of short presentations, and then I'll ask some questions. So I have the most fun job here. I get to ask the first questions, and then we'll turn it over to the rest of you. So with that, Christina Severn.
Morning, you guys. Thanks for having me. I run and a co-founder of an organization called Community Care Cooperative. I can't recall whether I have a slide in here. If I do, I'll skip it. So just two seconds on Community Care Cooperative. We used to call ourselves a startup, and then some staff people said to us, I think using the term startup doesn't really serve us anymore. Let's transition to calling ourselves a young company. So we are a young company founded in 2016 by federally qualified health centers, 330 health centers, originally 9 and then 15, and now we have 17 health centers. They both own the company. We are a 501c3. And they participate as the primary care network in our accountable care organization with the Massachusetts Medicaid program, which is branded Mass Health. And we serve Mass Health beneficiaries. We are about the largest new accountable care organization in the state, and we do business on a statewide basis. And to the best of our knowledge, we are the largest FQHC-based accountable care organization that takes sort of two-sided total cost of care risk. So if we exceed a budget, we get some, we pay money back, and if we save money off of a budget, then we get some of those shared savings back. The background on this is that until quite recently, until this ACO program, Mass Health had been running on a so-called 1115 waiver program from the federal government for many, many years, for 20 plus years. That program was a kind of a classic MCO program. There are a bunch of Medicaid health plans in the market. They had contracts with state government, they had provider networks, they paid fee-for-service claims. The state was looking at the cost growth and said, time out, this just isn't working. We're not sure that an ACO model will work, but we have some optimism, and we feel like since we know this isn't working, it's time to try something new. There's a whole side story there which had to do with how Massachusetts had passed the healthcare reform bill, Chapter 58, and then passed a cost control bill in, I'm going to forget, so I'll say roughly 2012. It was called Chapter 224. Part of Chapter 224 required the state to get a certain percentage of individuals in the Commonwealth under value-based payments. So an ACO program is also a way to further that objective. At the bottom of the slide, it's funny because sometimes I run into old friends and they say, hey, what are you up to? I heard maybe you were working with health centers to start a new company. And I'll say, oh, yeah, we did. And we have 120,000 members. And, In our first year, we were managing over $500 million in total cost of revenue and $44 million operating revenue. So it was a very sort of large-scale day one company. Of course, this, like most 1115 waivers, this waiver came with money. There's lots of jargon in healthcare. You're experts on that. This money is called the DSRIP money. It's about money for investment payments. This contract came with $1.8 billion. A good chunk of that money gets passed on to ACOs to make investments in pop health, social determinants, et cetera. Given the topic today, I thought it would be interesting just to touch on what Massachusetts has done with regards to incorporating aspects of social determinant into their risk adjustment methodology. So all state government and managed care plans use a risk adjustment model. Like Massachusetts, Medicare models tend to use HCCs, Medicaid models tend to use a DXEG. That's what Mass Health does. They use version 4.2. So they took that base Medicaid model of DXEG, and then on top of it, they worked with UMass Medical School to develop an adjuster for social determinants. And what you see here on this slide are the items that get incorporated into that risk adjustment down to the individual member, right? And then, of course, aggregated up at the ACO level, but this is all down to the individual member. So this includes things like, is the person experiencing housing instability or issues with tenancy preservation? That can be marked in two ways, either with that Z code that we love, 59.0, or through demonstrating lack of stable housing through having 3 Mass Health paid claims in a rolling 12-month period is also enough for the individual to ring the bell on unstable housing. In addition to that, Mass Health also created something called a measure of neighborhood stress and put 7 items in there that get aggregated to calculate a score for neighborhood stress. And you can see what they are here on the screen. I won't read them, 1 through 7. And they garner those items off of U.S. Census Bureau tract information. And then the last distinct thing, so 1, housing, 2, neighborhood stress, and 3, is recognizing that individuals who are low income and so they're eligible for Medicaid and also have involvement with the Department of Mental Health or the Department of Developmental Disabilities also garner additional, understandably have additional complexity and therefore are further positively risk adjusted. So this is one of the many, many innovative things that's happening within the 1115 waiver. I'm not aware of any other state that's doing something like this. Along the same lines of that $1.8 billion that was on the first slide of this DSRIP money, a good chunk of it, you can see the money in the first big bullet, is going into a program called flexible spending. So this is a program administered by Mass Health and then down to the ACOs that says, hey, ACO, every year we're going to give you a certain amount of money. And it's not literally a debit account, but that's how I think about it. There's a certain amount of money that we are allocated every year, and if we don't use it, then it goes back in the pool for everybody else to use. This was a long negotiation with CMS. I think the original vision of Mass Health had been more robust than where this landed, which is around nutrition and housing support. And when they put out a white paper about the entire ACO program, including what they wanted to do on SDOH, we supplied feedback saying your ideas are great and we think there are other social determinants that are really important, like access to quality preschool and ensuring that kids are reading at level in grade 6 and ensuring that young parents have adequate sort of budgeting skills and other agency and executive function to make them successful with themselves and their children. And Mass Health was actually incredibly interested in those ideas. However, they weren't able to negotiate through the finish line with CMS on all of them. The good news remains that there is a material amount of money to spend on nutrition and housing support. We cannot pay somebody's rent month after month, but we can cut a check to stabilize somebody's housing, to do improvements within the home, to give the individuals access to food that may be medically tailored food or may just be sort of regular grocery food. This program is going live. It took a long time to negotiate it. So it will go live January 2020, which is just about 2 years into the 5-year waiver program. So then lastly, wanted to talk about work that we've been doing on social return on investment for 2 reasons. 1, because it is really where our passion is in this company, and 2, because we've been collaborating with a group from Dartmouth, who I get to smile at in the audience right now. So, you know, when we started the company, we were interested in health centers, we were interested in low-income populations, all of that stuff. And the reason why we're interested in that, right, is because probably like you, we ultimately see access to health care and access to having recognition of the importance of social determinants and an organization that wants to have a meaningful impact about that, really ultimately less about health care, more about health and more, you know, really about social justice. And so, although we get very caught up in the day-to-day worry list, which is how are we doing with the budget the government gave us this year, and how are we doing on the 21 quality measures that we're responsible for in this contract, how do we also drive toward our highest goals and objectives? And so this work really reflects continued focus on our highest goals and objectives about having a social justice mission and everything that that means. We think the good news, so everyone is talking about social determinants of health, right? It went from what does that mean to being very, very in fashion. Mostly we think that that's good news. We also think that there's some danger there. And the danger that we're concerned about is that in our state, the Commonwealth, or nationally Medicare or other interested parties, think that healthcare entities like C3, like an ACO, like a health system will be a panacea for addressing social determinants because they have the money, and if they want to get a return on their total cost of care budget or their quality measures, that's the value prop. And the facts are that that's just not true. Certainly there are some what we call health-related social needs that are impactful on total cost and on quality. An example would be a person with a complex mental health need, perhaps a substance use disorder, with difficult to control diabetes and lack of stable housing. I think we would all agree that meeting that person's needs, including safe, stable housing, would decrease acute care utilization. However, for a lot of these other things, it's not going to be impactful on the total cost of care budget in the month, in the year, probably in the decade. Of course, it will longitudinally, as those issues create clinical pathology, and in many cases, the data would say premature death. So we wanted to say, is there a way that we could begin to think about a theoretical model for studying aspects of social determinants of health, putting aside any impact on total cost of care? That's what the project has been about. And so we've been able to get to, you could call it an alpha, you could call it a proof of concept. And that's what I'm showing you right now. And so what we're saying is, well, what if we looked at, in this case, 6 aspects of social determinants? And they are avoidance of juvenile detention, improved access to educational outcomes like graduating high school, for example, increased economic stability, improved food security, avoidance of foster care involvement, and avoidance of emergency shelter. And what if we could study the literature in terms of what the known economic impact of these things? For somebody who doesn't graduate college, what's the negative impact on their wages over time? For example, if somebody has foster care involvement, what is the average taxpayer burden of that, or state government cost of that? And so standing behind this graph is an Excel workbook where we now are embarking. We have a grant from an agency in Massachusetts called the Health Policy Commission. It's a grant it's a social determinant of health grant. We are aiming to enroll 300 people in this grant and do many things in addition to this. And so when we have, for example, somebody enrolled in this program and it is a youth, and that youth has a history of perhaps not being able to attend school on a regular basis, is at risk for dropping out, and has had some involvement with the court, The grant allows us to pay for an attorney, a child advocate, who comes in and works with the family. And if we're able to measure during that time period that that has decreased and then stopped the family, the youth involvement in juvenile justice, we will mark it and we will collect the economic value, sort of lather, rinse, repeat for the duration of this grant, which is 18 months. At that point, we hope that we have something. Best case scenario would be we have something and we say this is no longer proof of concept or an alpha, we're now going to call it a beta. And then what we would want to do is to pitch it to somebody like Robert Wood Johnson, for example, and say, hey, we think we've just proven something in a pretty robust alpha environment. Would you partner with us to now sort of take this to version 2.0? Because I think it will take significant investment dollars, a lot of rigor around the research and the economics, et cetera. So this is just a start, but we're pretty excited about it.
Great. So I'm Sally Kraft. I'm the Vice President of Population Health at Dartmouth-Hitchcock. And I'm going to move us from a very macro view of the social determinants of health to a really micro view of the social determinants of health. I'm going to talk about an example at Dartmouth-Hitchcock of the work that we're doing to implement social determinants of health screening, a little bit about the measurement. And I want to start off with really differentiating here between the social determinants of health for our attributed populations and truly health equity and really community partnerships. So as we've made this evolution, all of us in healthcare, from episodic treatment of disease, value-based purchasing, hospital-acquired conditions, to the ACO concept, prevention, what percent of your attributed population is getting their mammogram on time, diabetes control. We're really still talking about the attributed population, right? The screening that we're doing in our health system is in that middle box. It's the patients who are coming to us. So yes, we're doing social determinants of health screening. Yes, we're looking at health equity issues. But really, I think the frontier is what David was talking about this morning. What is the community that, and it may not be our patients all in that community, but those are the communities. That's the community health needs assessment, which I think is actually different than the patient's social determinants of health needs. So I just want to keep that in the front of our minds as we're talking about doing all this good work. We're really still talking about a subset of the population and of the community. So here we are, as you drove up here or flew in and then had to take an hour and a half at least car ride to get here to Hanover. We look really different than Rush Medical and Cleveland Clinic and Boston Centers. When you look around here, what do you see? You see granite boulders and lakes and mountains. What you don't see are YMCAs. You don't see Boys and Girls Club. You don't see a plethora of community-based organizations to help out when we find a social determinant of health need. Rural America, although we're only 17% of the population, we are sicker. We have less resources available to us to help. And the concepts of how do you address a positive social determinant of health need is very different than if you're in an urban center where you have really a number of organizations that can give you a hand and a number of organizations that already exist to respond to those needs. In addition, the solutions that we have in Hanover or Hartford or Enfield, these are very, very small communities. These are, we're not attracting a lot of big investors who go, wow, if I can invest in that solution, I can take it to scale. A lot of our solutions are very community-based. So we have a lot of challenges that, it's the typical thing when you say to the doc, why are your performance scores low? My patients are sicker. I'm not going to say that all of our challenges are going to be challenges that only rural America is dealing with, but we do have a series of challenges that are probably unique to our community. So what did we do? It was really interesting, Christina, to listen to your story about how the 1115 spurred a lot of your work. Indeed, here in New Hampshire, we have a 1115 delivery system reform incentive program, DSRIP program, that mandated that we begin social determinants of health screening, in addition to other screenings related to mental health and substance use disorders. So we put together a screening that we're using here at Dartmouth-Hitchcock, and we're working, and we've already built it directly into our electronic health record so that when the patient can actually have the screening done before they come in for their visit through the patient portal or on a tablet when they're waiting in the waiting room before they see the provider. Just building this screener, get ready, you guys, put your seatbelts on because it's going to take you a while. And there are many evidence-based questions out there, but to tailor it for your health system to get the buy-in of your providers and your patient populations, it will take a while to do that. And what we've done with that screener as we've been implementing it in a phased-in manner at this point in time, is we've been able to aggregate this data. And what we are showing here is the tree of needs. Again, these are the tree of needs for our patient populations. Housing is a big need. That will probably be a common need across all populations, urban or rural. Financial assistance, behavioral health, other client goals. In other words, what we're doing is we're able to look at this in a macro setting and allowing this macro report to start to drive interventions at the health system level, but also interventions at the community level and the policy level. And we have coupled this type of a report with the community health needs assessments that we're responsible for in population health. So we're really working hard to see not only what are the needs of our attributed population, but are those the same needs as the communities, and then how do we leverage community relationships. But here we are in New England, beautiful covered bridges. Unfortunately, sometimes that covered bridge leads to a drop-off. And that is exactly what we have found in our social determinants of health screening. We turn around and we go, housing. We don't have very many resources for people who are looking for shelters and for housing up here in the rural environments. So we have to, our health system had to say, if we're going to do the screening, we better be prepared to make the investments in the solutions. I'm going to show you one investment that we did make. We don't have community health workers in our communities. Some communities we do. Some of the larger urban areas of New Hampshire, for example, in Manchester, there is an existing community health worker program, but up here, there is no community health worker program. We couldn't call 1-800 or 603 community health worker. So we had to develop our own program. And we have developed that program using the best evidence and the best practices from across the country. We've had to tailor it specifically to what does work in a rural environment look like in contrast to an urban environment. And we have embedded those community health workers as members of the healthcare teams. And we monitor very closely the work that they're doing and the outcomes that they're getting. One of the things when, as you start to work with social determinants of health and actually creating these programs to address that, you have to ask, where's the beginning and where's the end? And what I mean is when you're homeless, how do you define what homelessness is? And then how do you know when you've met the needs of the patient who is homeless? What is stable housing? We borrowed very, very heavily from Mark and Sarah Redding in Mansfield, Ohio. And they've actually reported their work through ARC, through a Pathways, the Community Hub Pathways toolkit. And we created these pathways, which for the clinicians in the group, think of them as care pathways, right? You know, patients admitted, take their vital signs, diabetes, how do you start to treat that? We've created a score of these pathways for homelessness, food insecurity, domestic violence, childcare problems, transportation, tailored to our environments and our communities. So we know when a patient comes into the clinic, says, I'm homeless, we have a kind of a severity of illness for homelessness. Are you really sleeping under, we don't have that many bridges, except for that covered bridge that I showed you, but are you really sleeping outside in a tent, or are you couch surfing, or do you live in your parents' basement, you're just sick of that? So, we can start to create some assessment of that severity and then walk through what does it take to meet the needs of that patient. This has been an invaluable tool for us for not only monitoring the quality and the efficiency of the community health worker intervention, but also to inform us as a program, what do we need to be focusing on at a macro level. So this graph shows you in total, as we started to apply that pathways tool, that you can see the different social determinants of health along the x-axis. And the open or not completed bars give you a sense of how hard is it to meet that need. So for example, you look at this and you go, housing, it's our most frequent need, and look at all that green. The need remains open for a long period of time. So that is the signal to us that we got to be thinking beyond a community health worker. We have to be thinking about what do we do with our community-based organizations to expand our housing shelters. We need our government affairs people to step in and say, how do we start to create some opportunities for investing in housing and to move housing forward as a state issue that not only the health system is here to solve, but communities coming together. What are the innovative financing mechanisms? Zuckerman spent quite a bit of time with us yesterday with our senior leadership team, helping us understand that as a health system, we cannot solve all of these problems on our own. What are those effective community partnerships that need to be created to help address those social determinants of health needs that remain open for long periods of time because we just don't have the resources? So I'll just end by the 2 points that I think are really important is, number one, as we're doing social determinants of health screening in our attributed patients, the patients who come to us, remember that's a subset of this larger sense of population and health equity. This is a population, but it's not the whole sense of community and populations that we need to deal with. And the second thing is that in rural communities, we have a different set of shortages and a different set of challenges. But the optimism that I have is that when we find a solution up here in the woods where we have the bears and the moose, I am certain I can take that solution and I can disseminate it to Chicago and San Francisco and Boston, because it's going to take a whole lot less resources to meet these needs than if you take something from Boston and Chicago. I just can't translate that here. I don't have a YMCA. I don't have a Boys and Girls Club. So I'm optimistic that the solutions and the innovations from our rural communities are indeed going to inform the larger United States. Thank you very much.
So about 10 years ago, I was approached with a opportunity/challenge. We were designing a medical school that was going to be rooted in social responsibility, social accountability, be able to train a new class or a new breed of physicians that would perform home visits as a core component, a mandatory core component of their undergraduate medical curriculum. And it was expected that during those home visits that they would have a increased understanding of the social determinants of health. And so when I was presented with this opportunity, I remember telling my boss, Dr. Joe Greer, if you're going to do this, you're going to have a sustainable way to keep households coming. And I've always operated under a 5-year grant type of cycle. I'm sure many of you are familiar with that cycle. And he was proposing a method that would basically have us work in perpetuity. And so, can we pause this for a second? Yeah. And so, So that would require us to have new strategies, right? So no more of the days of being able to recruit somebody, work with them for 5 years, and then move forward. We would have to work with them and continue to work with them over time. And so as part of that, I decided we needed two key things. One, we needed to hire individuals from the areas that we worked in. And two, we needed to create a tech solution that would allow us to scale the work that we were doing in the communities. And so today I'm just going to talk very briefly about one of those things that we did, and that is we created this thing called the health risk profile. And what the health risk profile does is it allows us to dispatch out into communities social-oriented, almost primary care practitioners for the community. So I want you to kind of orient yourself around thinking about social service agencies as specialists, right, in the healthcare model, right? And so you need to have somebody who knows when to tell who where to go and at what time and what equates elevated risk versus primary risk. What things can we do at the point of care in the home versus the things we need to send somebody to an office to deal with? Because let's be honest, the average individual does not have time to keep going from one to the next social service agency. It's not realistic. That's not how people live their lives. So how are we going to meet their needs? So I think, I do this presentation where I talk about the 3 reflections I've had in doing my work. And it's distance, dinosaurs, and those damn do-gooders. Okay? Distance is, we have to find a way, and this tool is about first reducing the distance between the provider and the patient, right? That's the first part of the tool. Second thing is that we have to stop building tools for our past patient. We have to build tools for the future patient. And the future patient expects things to be on demand. They do not expect people to do for them. They expect to be able to do it for themselves. We build our own furniture. We design our own shoes. We print our own shoes. Why are we still trying to provide everything when patients can provide for themselves? And so that's the second part of it. Get out of the dinosaur mentality. And the damn do-gooders. Stop training people to work in weekend service blocks. That's not how people make progress. People make progress through continuity and consistent service to them over time. So stop having us train students in public schools to do, weekend 20-hour commitments. You're not teaching them how to make change in communities if you're teaching them a repetitive habit that does not work in the real world. So that's the other part. So let us go to my tool now. So the tool basically tracks every household that we work with because we have coined this phrase, household-centered care. Household-centered care is whoever is inside those 4 walls when we walk through the door is eligible for our services. And we bring in, based on the triaging we do through what we call a rapid risk profile, 5 questions that we ask on the phone call before we go anywhere that lets us know who should be going to the household, how soon they should be going to the household, based on their clinical and social risk. And so we look at 10 domains of risk, right? And so I have just a couple here, but we look at 10 domains of risk and we track this with the household for as long as we are working with them. And we code it over a continuum because the social determinants of health are not a dichotomous variable. They operate over a series of gray, and so you have to manage them over a series of gray. Also, they don't all apply at the same way in the same element of the life course. So we have one that's designed for youth. We have one that's designed for adults, and now we're bringing online one that's for the aging population. So now we can track and understand the changes in the social determinants of health, both vertically and horizontally, so that we can provide the best care. Last point I'll make is that we work with the most risky of risky patients. So I'm not saying this is the solution for every patient you may ever see, but you will always have a group of patients who drive the most cost, are the most difficult to work with, and what expertise will you turn to work with that patient? Who do you call? What do you do? That's what I'm trying to provide to the health system, is that solution. And so we originally did it with the students. We translated it to a model that can be consumed by the healthcare systems locally, and now we're going to scale it even further by partnering with my colleague here, Norberto, to build the tech system broader, expand the ability of the field teams to do their work with more households, with less time and less effort. And the way we've done that, just to give you one example, is we've identified typologies of households, right, based on SDOH risk. And so we have two right now, two typologies that we're working with, asset and capital household types. And those two types of households enable us to know how much time we should realistically expect to have to work with that household, how much resource, how much money we will have to allocate to you based on your typology and based on the system, and track you and how you move. What I have here on the screen are two diabetic patients emanating from two separate households. And so the diabetic patient is in the star. And so risk is tracked from red to orange to yellow to blue to green. And so yellow is where most systems are content in leaving people, right? You're surviving, you're in the safety net system, I wish you well from there, and people just kind of vacillate and bounce back and forth from there. We move and deliberately track where you go beyond that. Because one thing that we forget when we talk about SDOH is protective factors. Can we build protective factors that will enable people to buffer some of the other risk factors that they may have in another domain? And so you won't know that if you don't track it and if you don't have a robust way of looking at it and then seeing how it translates over time. Last point I'll make, and then we can just run this quick thing so you can see how different these households change, but with the same diagnosis, is that at the end of the day, what we're looking at is we want to reduce, when we talk about the business case for the SDOHs, we want to reduce the number of urgent risk people have, and we want to reduce the amount of time they keep that burden over their lifetime. And so if we can make meaningful change in those two areas, that translates to value, real value, not just for the health system, but as was aptly made by my two colleagues, but to the entire system, whether it be education, housing, et cetera. But once again, we have to track it accurately. We have to drive workflows that will enable people to do this work in a meaningful and purposeful way. And then I think we will see real change, sustainable change. Thank you.
Thank you. My name is Norberto Menendez, and my approach is going to be a little different. First off, I want to thank Jody for bringing us here and for making this happen for us. Luther, Jody, and myself have connected over time, and it's really we think we can bring a lot of synergy to the health system. But I'm not from the health system. My background is in technology. I was born in Cuba. I've lived in Spain, in Europe, in Brazil. I saw the young lady from Brazil that spoke earlier. I spent a lot of years, I lived in Brazil, and I know exactly what she's talking about. And I spent a lot of time in Canada, and I've seen the health system. I've always been very observant. I've been in technology since I was 17 years old. And so I was lucky enough to end up working at Apple and doing a lot of work there. And one of the things that I saw at Apple that we don't have in the health system today is an ability to focus on the problem instead of the distractions. We end up focusing a lot on distractions and trying to compare this to that and whatever instead of trying to solve the problem. And I think that the approach that we're taking is going to help change it, and the approach has to be based on resilience, like Lou was talking about, and on allowing the people to have the tools that allow them to effectively transition from where they are to where they need to be without a nanny. And so the other thing is that I think that healthcare needs, I want to thank Oleg and everybody for making all this happen. So I think I'll tell you when to pause if I remember, because we put a movie. We took a different approach. We created a healthcare platform. We wanted to focus on creating a platform that focused on all the needs. We took a look, you can just let it play. We took a look at the existing systems, and we thought, frankly, from a technology standpoint, I don't understand how healthcare buys the systems that they do. They spend so much money in such crappy systems that really reduce productivity. They cost you humongous amounts of money, humongous IT teams, and really no progress made. So we didn't want any of that. So we basically create a platform that connects to existing legacy systems and allows you to manage everything with one platform, with one set of companions. We call it an EHR companion. And with simple tools. Apple didn't invent the smartphone, they just made it easy to use. And so it's the same approach that we're taking. And so we're trying to establish a platform that provides a foundation where you can get all the data about a patient. And the data about a patient is not only the specifics about their condition with diabetics, but it's also their social determinants of health, and it's also how much time they have available for healthcare, and all those kinds of things. And so we created a platform to do that. We have partners today that are working with us that have been amazing. So in North Carolina, we're working with Cone Health and with an ACO, Triad Healthcare Network. And we're talking about bringing all the work that Lou is doing to that. And they're interested in using this platform to help people get better. And so that's all I wanted to tell you. I wanted to tell you that we're working on technology. We're trying to make it simple. We're trying to make it accessible. And I know there's a lot of challenges. I'm just looking forward to the questions about, how are you going to get technology to people? But we get them technology for other things. We spend a lot of money on other things. And so we think with a combination of the platform and the approaches that Lou is creating and integrating everything in a healthcare system, we're going to be able to transform the delivery of care.
Okay, great. So, boy, I wish we had not only till 11, but till about 11 tomorrow, because this has brought up so many interesting questions. And I thought I would start a little bit with Christina with the presentation. So we've gone from Medicaid at a state level to hospital system to people with their applications, kind of the whole spectrum here. And I was interested in how your team is using the literature to come up with potential wider lens benefits and such. Now, I know in the business world, sometimes things are driven by the 3-month market call or by the 1-year budget. And I imagine in governments that there's an administrative life cycle, this administration, this budget year. What have been people's reactions to this longer term planning? So this, oh great, thanks Alex. Saying we're going to do this intervention now and we're hoping to see less use of youth services so many years down the line. How's that going?
Well, there's no straightforward answer. So one of the nice things about having a network, a primary care network that is FQHC based, is that they've been doing this work for decades, right? It's not new work. It's new framing around working with an ACO and working with state government, but health centers have been leaders in trying to address issues of chronic stress and violence and housing security and food security forever, right? A lot of what they do is much more about social health and less about clinical pathology. So it's really taking what, and when we meet in Massachusetts, different stakeholder groups, an example would be talking about having a stakeholder group led by state government to think about how we can evolve the behavioral health system in Massachusetts, okay? And so the facilitator might say something like, for example, what are the impediments or what are people's thoughts around being able to integrate behavioral health or co-locate? And so our response to that is, well, yeah, that's what we do. We have completely changed that model, right? We have full behavioral health integration. Some of our health centers are SAMHSA level 6. So, some organizations are sort of now being brought into this because it's a good thing that the landscape is changing and other people are becoming part of the conversation. It's also where health centers, because of what their mission has been, which is serving the community, right? Not just serving the healthcare needs of the community. They sort of have 20 years leapfrogged everybody else. It's good that others are trying to catch up. So doing this stuff is not really, some of the stuff is, we've brought new software. We've brought new ways to sort of create a Cadillac enterprise data warehouse, right? So we have claims data, we have all their EHR data, we have all this data assets, so we have a lot more insights and we can give them new information. But a lot of what they have been doing, and other organizations like them in Massachusetts, has always been, about universal social determinants and screening for violence and screening for substance use disorder, et cetera.
Thank you. Thank you. Sally, I was going to ask you about the how you're calculating risk return on investment, but I changed my mind a little bit because as I saw your slides, I was really struck by the green and white bars and the different things. And from when I was doing the work with you here at the health center, I remember our community health needs assessments being a lot different. That it was obviously the opioid epidemic and transportation was on there also, but also mental health and access for elderly. But the biggest bar was housing. And so maybe in this theme of the wider lens, is that because of the subset you're working with, or is that because of an unmet need, or is it because you're actually asking the voice of the customer, of the patients?
All of the above. A lot of those SDOH screener results that I had up on the board we have started with our Medicaid population, so it's obviously a population with a lot of financial insecurity, and we actually map out the different social determinants of health to see where there are correlations with each other. And we know that financial insecurity is highly correlated with housing insecurity. So I think that's no surprise. Your comment about the community health needs assessment is really important, Rob. Everyone in this room, this is a huge opportunity. Why don't we standardize CHNAs across the United States so we can actually use the data to drive real change? David, you talk about getting sector change. I love that idea. Everyone does a community health needs assessment differently. So we can't possibly measure from one community to another, let alone one state, let alone one region. A lot of times on a community health needs assessment, housing doesn't come up. People don't think of housing as a health need. We all do, but not everyone does. So when you look at the differences between the CHNAs and the social determinants of health, a lot of those differences arise because of the way we ask the questions and how those questions are being framed. I think if we could standardize, and I'm really advocating in the state of New Hampshire at least to standardize the CHNA, think of the information that we could learn on a state basis, and then get Vermont and Maine, start to think regionally, because it's going to take big dollars to make a difference on housing. They're huge dollars. They're not dollars that Dartmouth Hitchcock alone can invest. But if we could start to activate multiple partners across communities to address that need, there will be a big benefit to all of our communities. And then we're really talking health equity.
Great, thank you. So Norbert and Lou, fascinating. You've given us a great bit of a teaser, if you will. So it occurred to me as you were both talking, the combination of the need to customize this for people and people with very high needs and high risk, but coupling that with technical innovation, what some people might call a socio-technical approach, which is always fascinating to me. Can you speak a little bit more? It might be a little counterintuitive that somebody with high needs and high risk would be able to work the technology, but I sense that there is a matching process and a coaching process. Could you talk a little bit how you make that socio-technical connection?
So I'll tell you my approach, and then I'll pass it over to my thoughts, and I'll pass it over to Lou. I think sometimes we tag things with wrong, and so we automatically think, well, if people don't have resources, how are you expecting them to get technology? But the fact is that when I'm 57 years old. When I graduated, the computer that I was using, I started working for a company that was doing a computer that was 10 million instructions per second. It was about the size of this table. And today, my watch, and it was $1 million. And today, my watch is $300. It can tell me if I had AFib. And it has much more than that power. And so I think the things that we want to do in healthcare are going to be empowered by technology. Can we reach everybody at the same time? No, but if we can get, we can get a significant percentage. We won an award for GE, and we did a project, and they told us, Hispanics in Miami are never going to be able to use technology, right? Well, we had people from 25 or 21 to 77 years old. And it turns out that the older people did much better with the technology than the younger ones. They were, in the sense that they were more engaged. And so if you can make it simple, and we also, I think, need to change the rules, and I try to do a lot of work with providers when we talk about bringing down healthcare to a level where people can understand it. We've all gotten a prescription, and you have a pamphlet that 3 PhDs read it, and they're going to disagree on what it says, right? I just want to know this lowers my blood pressure. And so if I just add that sentence, and then you attach the 27 pamphlets and all that stuff, that's great. But we need to bring it down so that the average consumer can see a graphic or can see an explanation that they can understand and that they can deal with, so that they can become an active participant in their care. That's what I think. I think technology, it's an enabler. I don't see it as a roadblock. I think the costs of technology are minimal compared to a visit to a doctor for an aspirin. And so I think that if we all start looking at it that way, we'll stop putting roadblocks that we don't need.
We work with somewhere in the neighborhood of about 1,600 households, 3,000 patients doing our home visits. Technology is vital. It's no longer a luxury. Whether it be, the patient portals that they interact with for their clinical care, or it's the student portals for their child who's in the public school system, or it is even the way they get paid. I have Haitian hotel workers who were having problems with getting paid accurately because they didn't know how to use the technology system that ADP had installed in their hotel. Technology is not a luxury. It is one of the reasons why we track and we look at and we intervene in that area. So Norb and I are working on a company called Humble Health, where our goal is to take and move individuals who will initially get these very high-touch services and move them to technology assistance, not just simply to support scaling that solution, but also to help build that resilience that we talk about, where individuals can drive their own realities, be more self-determined in the systems, because the systems without the education and the resources and the knowledge of how to work within them, we're not going to see sustainable gains. And so, can I make one quick point? So early on in this process, I think we probably all would agree with this. Finding individuals who support what you're doing at the highest levels, I would be remiss if we had this conversation and we didn't talk about that value in making a business case. Everyone is not on board. I remember my early days working in the break room doing this. The only person who would come up is Jody and talk to me about this stuff. And then even when we came to translate, it was Jody who did it. And I think it's no accident that she came out of this program, and she's the only one that really would work with us on that. So I think there's also a layer of this of advocacy at the top levels of the policymakers to make this really go.
And Lou, just in follow-up, do you have as part of your team people, I'm interested in kind of the intake process and how your patients get started with using the technology. Is that part of your team's work there?
Yeah, so that's built into the approach is from So I mentioned earlier about the rapid risk profile. One of the things that we find out very early on is their capacity as it relates to technology. We tailor that rapid risk profile based on who's the referral source. Originally, we didn't take referrals from health systems. We only got it from social service agencies because our sense was that if you really subscribe to the social determinants of health, the social determinants of health are rooted in prevention, not mitigation. And so if you want to go upstream, you have to go to the places they're going to go to first. People will feed themselves before they will go to the hospital unless they, drop out, right? That's just natural, human beings, right? And so, why go to the hospital? I want the riskiest of the risky. And they're at places that I want to get them early. And so that's the strategy we use.